All right, so welcome back to everyone that's been following along. Now, if you're watching this playlist from the beginning to the end, there's a lot that's been happening. But in case you're not and you're just delving into reproductive pharmacology, remember that I always do a little revision of what we've covered so far, right? So today, earlier this morning, we finished up with penile pathology, and we've basically looked at all of reproductive pathology. And I wanted to do a quick summary of what's happening, right? Because it can seem pretty overwhelming sometimes. So one thing we looked at that was probably the bulk of all of this was the ovarian cancers, right? And they were divided into whether they were surface epithelium, germ cell, or sex cord stromal ovarian cancers. And then on top of that, they were further divided into benign versus malignant. First aid compares benign ones in one list and then malignant ones in a separate list. They don't really talk about them together. So when I made the video, I spoke about them together, and this is where I'm going to kind of do a quick summary of what we've done so far before I move into reproductive pharmacology. Um, so surface epithelial ovarian cancers. Benign ones are serous and mucinous cystadenoma, right? There's a serous cystadenoma and a mucinous cystadenoma. The malignant ones are named the same thing, serous or mucinous cystadenocarcinoma, right? Which now, based off of pathology, the naming tells you it's malignant. Both of the serous cases, the malignant and the benign one, both serous cases are bilateral, which is a big deal. The benign serous condition has fallopian columnar epithelium on the ovary instead of cuboidal epithelium, and both mucinous cases have mucus. The benign mucinous condition is large, while the malignant mucinous condition has so much mucus it's even in the peritoneal area. Right? So that's generally the summary of what the surface epithelium ovarian cancers are, and you should be able to talk about this stuff without the book in front of you by the time you're ready, right? So the reason I'm showing this here, I could talk about it without the book in front too, but the reason I'm showing this here is so you can actually see and follow along. But this is how you want to be able to kind of summarize it without looking at the book. And then you move on to the germ cell class of ovarian cancers. The only one germ cell cancer that's benign is the mature teratoma, which is also called the dermoid cyst. That one is a mature one, so it has mature people thing. It has teeth, it has hair, and it can also have monodermal thyroid tissue, right? But this is all benign. The malignant germ cell ones, there's three of them: dysgerminoma, immature teratoma, and a yolk sac tumor. So I wrote here, think of it as this way to kind of remember them. There's dysgerminoma, the germ part helps you remember it's a germ cell one, an immature version of the mature one, and a yolk sac one, where remember yolk sacs, the yolk sac, when we were doing embryology earlier from first aid, we said that the germ cells came from the yolk sac, right? And in case you forgot what that was about, way in the beginning when we looked at some Kaplan notes, we were up to this part right here, right? You can see how your primordial germ cells come from the yolk sac and then go to your indifferent gonads. Okay, so that's why a yolk sac tumor being a germ cell cancer is not so far-fetched to remember. So dysgerminoma, what is that? A dysgerminoma is basically the female form of the male seminoma, and both of them, the male seminoma and the dysgerminoma, have fried egg cells, okay? The dysgerminoma also has HCG, which means that you can have a positive pregnancy test in this female patient, but she's not going to be necessarily pregnant. She's actually going to present with an adnexal mass, as you do with most ovarian cancers, and there's also going to be LDH. The immature teratoma is the one that has the immature things. So the mature one had teeth and hair, and sebum and thyroid tissue. The immature one has fetal tissue. That's it, and it's much worse because it is obviously the malignant form. The yolk sac tumor is yellow on gross examination, and it has Schiller-Duval bodies, right? High alpha fetoprotein, nothing crazy there. Then you have the last class, the sex cord stromal ovarian cancers. There are three benign ones, and these are pretty high yield. They get tested pretty commonly. The three benign ones, there's fibroma, Sertoli-Leydig, and thecoma. So fibroma, thecoma, you can remember because they're both omas, and then Sertoli-Leydig. This is also easy to remember because here you cover the Sertoli-Leydig cells in the benign version, and then when you look at the malignant version has the granulosa cell. So that's everything. All right, the fibroma you can also think of as tribroma. It has the Meigs triad of ovarian fibroblast, liver ascites, and respiratory pleural effusion. So patients present with all three symptoms. Sertoli-Leydig cells, this is not supposed to be stuff that you found in a female, right? But if you have a Sertoli-Leydig ovarian cancer, it's going to have testicular histology with tubes and whatnot, and it's going to make testosterone, which is going to cause this woman to virilize. The tecoma is the one that makes estrogen. And the way I remember that is because fibroma has fibrosis, sertoli latex has testosterone, so the only thing that's really left is the tecoma has estrogen. And estrogen, remember, is not that great of a hormone for women in excess at all, because it causes endometrial thickening, which always leads to endometrial bleeding, and it's going to be abnormal uterine bleeding. Right? Your estrogen and progesterone levels have to be maintained together. If you only have a lot of estrogen and not enough progesterone, you're not going to maintain the endometrial thickening. The malignant sex core stromal tumor is the granulosa cell tumor, which is the one that makes high amounts of estrogen like crazy, which is far worse than the tecoma is. And you're also going to see Call-Exner bodies, which you're supposed to remember call granny, so call granulosa, Call-Exner bodies, granulosa cell tumors, right? Not so bad at all. The only non-classified ones were the other ovarian cancers, and they were the benign Brenner tumor and the malignant Krukenberg tumor. The Brenner one is just B's, all B's. Brenner, benign, coffee bean, and it has bladder epithelium, right? Krukenberg is something we've already seen in GIT. It's a bilateral metastasis of a GI cancer. So you're going to see GI stuff, which is mostly just mucus cells. All right, so that's your ovarian cancer review. The only cysts that we were worried about that we need to know for the test are the follicular one, which makes high estrogen. So, of course, estrogen leads to endometrial thickening. And then the theca lutein one, which is a bilateral group of cysts related to choriocarcinoma or hydatidform moles. Nothing crazy there either. Right? And then we looked at some uterine conditions like adenomyosis, leiomyoma, endometriosis. Right? Just a couple more notes to remember them. And then the basic breast diseases, right? You could either have fibrocystic changes, which are bilateral, premenopausal in age, right, 20 to 50, and you're just going to have stromal fibrosis. Nothing excessive, though. There's a lot of things that you won't have, like a huge mass, and etc., etc. Fibroadenoma, again, occurs in a pretty young woman. Here, you're going to have a mobile mass that responds to estrogen, so it gets bigger when she's menstruating, for example. Right? The intraductal papilloma, which is pretty problematic. Since it's intraductal, it can cause nipple discharge, and it can become cancer. And then the last one was the Phylos tumor, which is just the one that had leaf-like lobulations, and even on histology, you could see like leaves that's, pretty unique to it, so you can get tested on that. And to cap things off, breast cancer, right? The non-invasive versus invasive, nothing extremely difficult about those two groups either, right? So you got to be ready with that. You have to be able to review that on your own, be able to talk about those things without really needing the book in front of you. And then we can finally, we looked at all the penile pathology in the last video. Nothing ridiculously hard here either. Right? We saw some of the germ cell tumors. Nothing else we really had to worry about. Just germ cell tumors here. A couple simple non-germ cell tumors, but they weren't that extreme or difficult either. And of course, the big case of BPH and prostatic adenocarcinoma. So that all comes down to finally leaving us at reproductive pharmacology, right? So now here we're going to see a bunch of medications that were kind of skipped over when we were doing endocrine, right? Endocrine did not really talk so much about testosterone and estrogen and progesterone and all of that. We did talk about GnRH in endocrine, but we didn't talk about GnRH with LH, FSH having major impact on these two organs, right? The ovary and testes. So these guys were not really discussed in endocrine so much. So here on this image, on the first page, you can kind of see there's an entire algorithm of stuff happening, right? It starts from the hypothalamus making GnRH, which then goes to the anterior pituitary to make LH and FSH. LH and FSH both have impact on the ovary, and only LH really has major impact on the testes. So let's look at the ovary side of things first. On the ovary side of things, we can see that you could take oral contraceptives or danazol, and all of that is going to stop your ovary from making anything. What is your ovary supposed to be making? It's going to make androstenedione and some testosterone. This testosterone, thanks to aromatase, will also be converted into estrogen, some kind of estrogen, right? There's 3 different types of estrogen being made, and estradiol can also be further sent for gene expression in estrogen-responsive cells, right? So this is the stuff you stop when you start taking tamoxifen or raloxifene. Here, these guys, the zoles, anastrozole, letrozole, exemestane, these are the medications that are actually aromatase inhibitors. So if you're taking aromatase inhibitors, you're going to stop the aroma, you're going to stop smelling like a sweet woman, you're going to stop the conversion of all these potent hormones into estrogens. That's kind of one way to remember that, right? So you're not going to have the conversion of testosterone into estrogen. So that means you're going to have high amounts of testosterone, which could be preferred depending on what's happening. Ketoconazole, we already know from antibiotics, and then danazole again. These guys just stop the P450 enzymes as well, so you stop making testosterone, right? That's another thing that you're seeing here, right? And understanding now, we're going to see where you use that. On the male side of stuff, same stuff, ketoconazole and spironolactone, they are anti-androgenic. They have anti-androgenic effects, so you stop making testosterone. Finasteride, notorious medication we've been seeing for BPH, for male pattern baldness. 5-alpha-reductase inhibitor stops you from converting testosterone into the more potent form, DHT. So over here I have one note, GnRH receptor antagonists like GnRH, it's not in the image here. GnRH receptor antagonists bind to the pituitary GnRH receptors and decrease the secretion of LH and FSH. The decrease in LH and FSH subsequently leads to decreased production of androgens and estrogen. GnRH receptor antagonists do not play a role in the medical termination of a pregnancy, but are used to stimulate the ovaries in assisted reproduction instead. Right, so GnRH, this is actually a pretty important medication in patients who are trying to get pregnant, so keep an eye out for that. Over here, other than that, they also show you clomiphene, which upregulates GnRH by blocking the negative feedback that hormones from the ovary or testes can have, right? So like inhibin and whatnot. There won't be any negative feedback, so you keep releasing more GnRH, LH, FSH, etc. Everything downstream. Here's a little NBME20 note. So NBME20 had a question about a man receiving HCG injections due to surgical removal of his pituitary adenoma. He also received other hormone replacement therapy. The HCG led to him developing gynecomastia. How? Right? How did the HCG really cause him to have gynecomastia? And that was a pretty far-fetched question in my opinion on NBME20. So this is because the alpha subunit of HCG matches LH, FSH, and TSH. The upregulation of LH will lead to more testosterone from Leydig cells. Then the testosterone will be converted to estrogens via aromatase, and that can cause gynecomastia. Right? But very far-fetched question in my opinion. It doesn't really seem like a very plausible thing that can happen. But NBME20 still somehow found a far-fetched way to kind of make that connection. So just a little thing to keep in mind about the alpha subunit being very similar to LH and FSH every time you have a question about HCG. So let's take a look at the actual notes before we start doing some questions, right? So here, first medication, leuprolide. Step 1, NBME, all of these guys, they love this medication because of the way it works. It's got a very intricate thing to it. So this is a GnRH analog with agonist properties when used in pulsatile fashion, but antagonist properties when used in a continuous fashion. And we saw this when we were in endocrine, that depending on whether or not something is in a pulsatile fashion or continuous fashion, its hormonal effects can be completely opposite. And this is a very good case scenario of that. So when administered continuously, this drug can be used in the treatment of advanced prostate cancer. When administered in a pulsatile fashion, it can be used to treat infertility in women. Right? So that's how this medication is extremely useful for these last two clinical uses, right? Prostate cancer and infertility right here. At the top I wrote, initial use will cause a transient rise in pituitary LH secretion, which leads to a rise in testosterone levels. However, continuous use suppresses LH release and leads to a decrease in testosterone production. With lesser testosterone, there will be lesser DHT production as well. To counter the initial transient rise of gonadotropins, adjunctive therapy with flutamide, which is like finasteride in a sense, can help counteract unwanted effects. Okay. Adverse effects, of course, would be hypogonadism, libido being lower, erectile dysfunction, and then nausea, vomiting is whatever. Right. So in this little image over here, you can see how leuprolide is stopping GnRH from working, so you stop everything else downstream. And that's going to be the continuous use. But if you have it in a pulsatile, very natural manner, then you can actually upregulate everything. Right. So depending on what you're trying to treat, you would give the medication in that manner. Estrogens like ethinyl estradiol and DES, diethylstilbestrol, which is a terrible medication you need to watch out for, and mestranol. All of these bind estrogen receptors. They're used for hypogonadism or ovarian failure, You can also use it for menstrual abnormalities combined with other oral contraceptives, and of course you need progesterone or hormone replacement therapy in postmenopausal women who might be having like hot flashes and bone weakness, etc. Adverse effects, of course, anytime you have too much estrogen, there's an increased risk of endometrial cancer, right? So you have to give it with progesterone, right? Progesterone is the guy that kind of not really counters estrogen's activity, but maintains it. Estrogen is going to make your endometrium thicker. Progesterone is going to maintain the endometrium until it's time to have your period. You can also have excessive bleeding because of the high estrogen, clear cell adenocarcinoma of the vagina in women exposed to DES in utero. So if your mother was taking DES, increased risk of thrombi because estrogen causes that coagulation. Contraindications are you cannot give this to anyone who has estrogen receptor breast cancer in their history, or a history of excessive coagulation, or if they smoke, because smoking tobacco also makes you hypercoagulable. Right? So estrogen's very scary medication to kind of use orally. Your natural estrogen is the best case scenario you have, and if your natural estrogen is not really working for you, gotta make sure you take a lot of progesterone too. Don't just take solo estrogen. The next group of medication are your SERMs, right? Selective estrogen receptor modulators. So you have clomiphene, tamoxifen, raloxifene. High yield medications, all three of them. And you're often asked to kind of pick between tamoxifen and raloxifene, so you really need to know the difference between those guys. Clomiphene is an antagonist at estrogen receptors in the hypothalamus, right? It's way up here again. And you see that in this image over here too. Clomiphene blocks negative feedback in the hypothalamus. So it's actually, right, it's actually an antagonist of estrogen receptors. Prevents normal feedback inhibition and increases the release of LH and FSH from the pituitary, which further stimulates ovulation. It is used to treat infertility due to anovulation. SERMs may cause hot flashes, ovarian enlargement, multiple simultaneous pregnancies, or visual disturbances. And that's true for the other two medications there too, because they're all SERMs. Right? So the way this is written in first aid, this statement should kind of just be up here because it's true about all three of these. Tamoxifen is an antagonist at the breast and an agonist at the bone, as well as the uterus. All right, so that's the problem. Being an agonist at bone is okay. An agonist at the uterus, though, makes it have this risk of endometrial cancer. So you use this to treat and prevent recurrence of estrogen receptor and progesterone receptor positive breast cancer. Okay. Tamoxifen is the only medication that you really use for breast cancer, though, not raloxifene. Right? So you're not really going to get a question where you're treating breast cancer and then tamoxifen and raloxifene are both answer choices and you have to pick between the two. You don't have to pick between the two because you can't use both for breast cancer. Raloxifene doesn't really necessarily work for breast cancer. Which medication are you talking about, Mohit? Which one can which medication cause damage to the uterus? So let me know which medication you're talking about and I'll let you know. But yeah, so tamoxifen, you have to use this medication for patients who have breast cancer, right? Estrogen receptor positive breast cancer. And then, of course, while treating their breast cancer, you're increasing the risk of their endometrial cancer, and you can't necessarily give them progesterone either, so you got to be very careful with that. Raloxifene is not used for breast cancer. Okay, raloxifene is an antagonist at the breast, just like tamoxifen. But the only major difference between tamoxifen and raloxifene is that raloxifene is an antagonist at the uterus, right? So being an antagonist at the uterus, it doesn't really have an increased risk of endometrial cancer, and it's used primarily to treat osteoporosis in postmenopausal women, right? Tamoxifen would be equally safe to use in a patient with a hysterectomy since they would not have an endometrium. So one of the cool things you can get a weird question on is that, using tamoxifen on a patient who doesn't even have an endometrial lining is perfectly safe, right? Because endometrial cancer can't occur in someone who had an hysterectomy. Can clomiphene cause damage to the uterus? No, not really. No, clomiphene won't necessarily cause damage to the uterus as far as I can see here. It's gonna kind of help you get pregnant. That's what it's really for. So you could use it to stimulate ovulation, because there's many different forms of not getting pregnant. Women can have difficulty um, getting pregnant for many different reasons. But if you figure out that one of the main reasons the woman isn't getting pregnant is because she's not ovulating, which means she might have, it might look like she's on menopause, but she might have some more eggs left. You can give her clomiphene. She will eventually ovulate, and then the parents, the husband and wife, they can try to get pregnant. But it's not exactly a guarantee, because getting pregnant is very difficult. But clomiphene will not cause uterus damage, though. Definitely not. All right. Next group of medications, aromatase inhibitors. Right. So aroma, you always think of a sweet-smelling woman, and when you think of aromatase inhibitors, you stop her from being a sweet-smelling woman. It can actually inhibit the peripheral conversion of androgens to estrogen. So you're gonna end up having too much androgens. Where can you use this? This is going to be great if you don't want more estrogen, such as in a patient who has estrogen receptor positive breast cancer. Right, so if you don't want more estrogen, you just take aromatase inhibitors, and you can help there. The induced estrogen deficiency may cause atrophic vaginitis, like vaginal dryness and pain during sex, as well as decreased bone density, since estrogen prevents bone breakdown by stimulating osteoblasts and inhibiting osteoclasts. And this is a little review of something that happened way back in musculoskeletal, right? We got to see what estrogen's real interplay was with the bone. So estrogen actually prevents bone breakdown by causing more osteoblastic activity, right? And osteoblasts make bone, and inhibiting osteoclast activity. Osteoclasts break bone. All right. So before moving on, I want to go back to the top, look at a couple of these questions over here, and then we'll look at the rest of what's there. So the two questions you see on the top, they're from USMLE RX, and then the one question at the bottom, that one is, I believe, AMBOSS. All right. So 29-year-old African American woman with menometrorrhagia, whatever that is, undergoes ultrasound of the pelvis that reveals uterine masses. Biopsy shows a whorled pattern of smooth muscle. A gross specimen from a patient with similar pathology is shown, right? And then you have this image of the pathology. The masses are most commonly associated with which of the following conditions, right? Now, when they mention this whorled pattern of smooth muscle, right, and menometrorrhagia, you should immediately at that point understand what's happening. Menometrorrhagia is like menorrhagia, meno being bleeding in your menstruation. So if you have a patient who's pretty young, 29, has bleeding, and then a whorled pattern, that's fibroids, right? Fibroids, and these masses are going to be enlarging with pregnancy. This is the classic presentation of uterine fibroids, and the patient has leiomyoma. These benign tumors are sensitive to estrogen and wax and wane in size, proportional to estrogen levels. Menometrorrhagia, or heavy irregular bleeding, is a common finding. And also remember that leiomyoma we saw was presenting in really interesting manners, right? Some patients were presenting with constipation because their fibroid was on the posterior part of the uterus, so it was kind of impinging on the colon, right, on the rectum. You can also have it in the anterior part, and it can kind of press down on your bladder, and you need to keep peeing, and all kinds of other places as well. So be very mindful that the location of the fibroids can actually cause different symptoms. The question on the right, an obese 35-year-old woman presents to her physician with a 6-month history of amenorrhea. She's concerned particularly because she and her husband have been trying for more than 1 year to conceive with no success. Results of physical exam are normal, except the patient has noticed darkly pigmented periareolar hair since she stopped menstruating. Blood pressure is normal. Lab studies show an LH of 300 and FSH that's only 5, right? So super high LH, very, very low FSH. TSH is 0.7, which is pretty normal. Results of a urine pregnancy test are negative. An ultrasound shows enlarged ovaries bilaterally because she has PCOS, right? She's the ideal, not the ideal, the simplest form of the clinical scenario of a patient, the typical form of a patient with PCOS, right? She's a typical PCOS patient, obese, has the dark pigmentation because of excess fat, right? She's going to have insulin resistance, right, which is also seen with the pigmented periareolar hair. She would also have periareolar hair because of her hirsutism, right? She's going to have high androgenic activity, and she needs more FSH. She needs more progesterone. That's what she really needs. So when they ask you which one of the following findings is most closely associated with her, anosmia would be in like Kallmann syndrome. They can't smell anything, right? Galactorrhea is irrelevant here. Polycystic kidneys was actually a trick answer choice because PCOS is polycystic ovarian syndrome, not polycystic kidneys. Hyperglycemia was the correct answer here, right? Weak pulses in the lower extremities occurs if you have the descending aorta not getting enough blood, right? Which can occur with the coarctation of the aorta. So again, all of these are completely different scenarios that are completely irrelevant to the question being presented. And at the bottom, we have a question from Amber. So this one says, a 33-year-old woman comes to the physician because of a 1-year history of irregular menses and infertility. Right, so 33 years, doesn't have normal menses, and she's having trouble getting pregnant. She has a history of an eating disorder and has received dietary and behavioral therapy over the past 6 months with minimal improvement in her symptoms. She's 5'7" and weighs 104 pounds, BMI is 17. Physical exam is significant for pallor and thin, soft, depigmented hair on the arms and back. After an extensive workup, the physician recommends pulsatile GnRH therapy. 1 week after initiating therapy, a pelvic ultrasound shows a 24mm hypoechogenic cavity in the right ovary. The patient subsequently receives a drug that results in resumption of meiosis and the loss of gap junctions between the cumulus granulosa cells and the oocyte. This patient most likely received which of the following drugs, right? And the way they worded the question was what really caught people off guard. But you should look at your answer choices and just know what you're trying to achieve in this question, and then figure out what will be the best thing to give this patient anyway, right? Because this last sentence that they gave her a drug that causes the resumption of meiosis and the loss of gap junctions between the cumulus granulosa cells and oocyte. What does that mean? That can actually be very very intimidating. Right, so only 19% of people got this question right. The answer here was HCG, but only 19% of people got this right. So what actually happened in this question? A patient with a history of an eating disorder, low BMI, pallor, and lanugo most likely has anorexia nervosa. And they gave you her BMI super low, right? 17. Which can cause infertility as a result of hypogonadotropic hypogonadism. Right? And we saw this earlier when we were starting reproductive pathology. So pulsatile GnRH therapy stimulates endogenous FSH secretion and ovarian follicle maturation. Resumption of meiosis, resuming meiosis, continuing on meiosis, and the loss of gap junctions between the oocyte and the follicle and the cumulus granulosa cells are changes that occur during ovulation. That's what that was about. So basically they gave her something that caused ovulation. Recombinant HCG, which is structurally similar to LH because of the alpha subunit matching, was most likely administered to this patient to induce ovulation. After ovarian follicle maturation is achieved with pulsatile GnRH therapy, as seen on the ultrasound with the 24mm hypoechogenic cavity in the right ovary, giving HCG would now assist in the ovulation. And that's really all it was. So when you saw this kind of question and you started getting lost, understand that the wording is not supposed to make you lose what's happening. You should know enough English to just at least know what the entire scenario was about. And this is a patient who has infertility and she's trying to get pregnant. Giving her HCG at this point would help with ovulation. That's all it's going to do, right? Giving LH, FSH, and progesterone is one of the best ways to help someone who wants to get pregnant, right? And that's kind of what you're doing in this question scenario. So, oh, and the first thing they did, right, where they gave her, initiating the pulsatile, where is it? Receive, right. The patient gives a drug with, no, not that part. Okay. Pulsatile GnRH therapy, that's basically going to be leuprolide, right? Pulsatile leuprolide. So that's what this question is kind of about. Okay, so next thing now, hormone replacement therapy, right? This is a very important thing that a lot of patients need if they maybe have early menopause for some reason, or they had to get surgery and get their ovaries removed, possibly because of cancer, right? So now they need the hormones that the ovary was supposed to be making. Used for relief or prevention of menopausal symptoms like hot flashes, vaginal atrophy, as well as osteoporosis, right? Which because of the high estrogen, has low osteoclast activity, right? And that's going to be problematic because if you are having menopausal symptoms of osteoporosis, right, and you don't have estrogen, then you're going to have more osteoclast activity, and that's going to break all the bone, right? So in hormone replacement therapy, you give estrogen to fix that. Unopposed estrogen replacement therapy, though, has an increased risk of endometrial cancer, so that's why progesterone has to be added. There is a possible increased cardiovascular risk, though. Hormone replacement therapy, HRT, is not safe. It's not safe, it's not perfect, but it is often necessary. At the bottom here is another AMBOSS question for the same medication we looked at and we've been saying is pretty important, leuprolide. So here we have a 64-year-old man coming to a physician because of a 1-month history of progressively worsening back pain that wakes him up at night. Right? So 64 and back pain, we might be dealing with prostate issues, right? He also reports symptoms of urinary urgency and a weak urine stream. Definitely sounds like BPH at this point. He has no history of serious illness and takes no medications. Rectal exam shows an enlarged and hardened prostate with nodular surface, right? Prostate adenocarcinoma. After further evaluation and confirmation of the diagnosis, he is started on a new drug. Initially, there is an increase in serum testosterone and DHT levels, followed by a sustained decrease in both hormone and DHT, right? Testosterone and DHT. Treatment with which of the following drugs was most likely initiated, and that's leuprolide, right? Just earlier we said that we can use leuprolide in a continuous manner, right, to treat advanced prostate cancer, right? But in the beginning, we set up here, in the beginning there would be an initial transient rise in hormones, right? To counter that unwanted effects that you can possibly get from the initial rise, you can add flutamide as well. Right, so here, when administered continuously, this drug can be used in the treatment of advanced prostate cancer. Leuprolide, when administered in a pulsatile fashion, it can be used to treat infertility in women. Leuprolide is a long-acting GnRH agonist that is commonly used to treat androgen-sensitive prostate cancer. When administered continuously, it causes downregulation of GnRH receptors in the pituitary, with a subsequent decrease in FSH and LH secretion. This manifests as an initial increase in serum testosterone and DHT, which you can counter by taking flutamide or finasteride, and then later on, both hormones are going to be decreased in levels. So that does get tested, the fact that it goes up and then goes down again. So you got to be ready for that. Next thing are your progestins, right? So progestins like levonorgestrel, medroxyprogesterone, gestrel, norethindrone, and megestrol. This is the only medication that doesn't have gest in it. All right, so be very mindful of that. It doesn't have the gest in it for progesterone. The others do. So norethindrone is a medication that they can just throw onto you, and you might be like, what the fuck was that? Right? They don't have a gest in this name. They have the rone of progesterone, but not the gest. All of these guys bind progesterone receptors, decrease growth and increase vascularization of the endometrium, and thicken the cervical mucus, right, which is all great for someone trying to get pregnant. However, it can also clinically be used for contraception if you give it with other stuff. Endometrial cancer, it can be helpful there as well, and abnormal uterine bleeding, because those two things occur from unopposed estrogen. Progestin challenge test we saw in an earlier video with a question is where you have the presence of withdrawal bleeding, excluding anatomic defects, and chronic anovulation without estrogen. Right? So as soon as you take the progestin away from someone, they start bleeding. right? And it's not due to estrogen, where you just have anatomic defects, and you have chronic anovulation without estrogen. So the progestin challenge test we saw much earlier when we were looking at PCOS, because that's somewhere you can actually use the progestin challenge test. And PCOS is a very high yield topic, so let's go back to that real quick right here. Right, this one, where does the sentence start? In patients with anovulatory cycles, the administration of progesterone would result in differentiation and maintenance of the endometrium, and subsequent withdrawal of the progesterone would cause withdrawal bleeding. Right, so anytime you stop giving progesterone and a patient starts bleeding, it's because stopping the progesterone stopped the gestational issue of maintaining the endometrium. So you stop progesterone, you start bleeding. That's how normal menstruation kind of works, and that's a positive progestin challenge, right? So that's your progestins right there. Antiprogestins like mifepristone, ulipristal, these two guys are competitive inhibitors of progestins at the progesterone receptor. These guys are used for the termination of pregnancy, right? You can give mifepristone with misoprostol to end pregnancy for an abortion, and for emergency contraception you can use ulipristal. Misoprostol is a prostaglandin E1 analog that induces ripening and dilation of the cervix to induce labor. However, it also induces uterine contractions, which facilitate expulsion of the fetal tissue if you're not trying to stay pregnant, right? It's a very important medication because abortion is also very important. And then I'm going to stop here for now. In the next video, we'll finish up with combined contraception, look at some contraceptive devices, talk about the tocolytics and danazol, and just the last few androgenic things that we need to know. And we'll be done with reproductive chapter.